Um, and I believe we are discussing hypomagnesemia. Okay. So I've started the discussion with this algorithm at the top of the chapter. We are not going to talk about hypermagnesemia in general. That is mostly iatrogenic. So hypomagnesemia has more complexity to it. So not unsurprisingly, it follows some of the same patterns that you've seen in the past, where urine magnesium assessment is one of the first parts of the diagnostic decision tree. You're going to use that to determine whether the kidneys are responsible for the hypomagnesemia or whether there's a non-renal explanation. So this again should follow the typical pattern that you recall for other electrolytes. Notice the thresholds for the magnesium wasting or making the decision about whether or not magnesium wasting is present. A urine mag of greater than 24 milligrams per day would be consistent in the setting of hypomagnesemia, would be consistent with renal mag wasting. And then you can see that there is an appropriate renal conservation response to hypomagnesemia when there is a non-renal response, non-renal explanation for the magnesium deficiency. Notice also similar patterns where magnesium can be redistributed or be lost from the body, either through renal or non-renal routes. Redistribution is a fairly small number of possibilities, hungry bones and pancreatitis. And then we have the extrarenal losses. One that is very common is intestinal loss of magnesium through inhibition of magnesium transport in the gut with the use of proton pump inhibitors. Okay, then we'll go through in our conversation the various renal magnesium wasting syndromes, and they can, in broad strokes, be divided into thick ascending limb defects, distal convoluted tubule defects, and then defects in multiple tubular segments. Notice that there is a decision point regarding where the defect lies surrounding urine calcium excretion rates. That should also look familiar to you when we discussed K wasting. Urine calcium is one of the ways that you discriminate between thick ascending limb defects, i.e., Bartter syndrome, versus distal convoluted tubule defects, i.e., Gittleman syndrome. So I have low urinary calcium when the defect is in the DCT, and when the thick ascending limb is responsible, I have a urine calcium that is not low. That's relatively high. Okay, so you'll use that same biomarker to target where the defect is when elucidating renal magnesium wasting. Okay, with that said, let's get through the text of the chapter. Again, the initial evaluation of magnesium deficiency revolves around whether this is a non-renal or renal loss. Okay, and again, we've discussed some of these thresholds. I won't belabor it. I will say, however, there's a little bit of um, friendliness to the memorization. That is, this threshold of 24 milligrams per day of urinary magnesium is equivalent to 1 millimole per day. So you can look this up to look up the molecular weight of magnesium, and you'll see that it's 24 grams per mole. So that makes that relatively easy to discriminate or to remember, or easier to remember. And then fractional excretion of magnesium is another biomarker. We've used fractional excretion of sodium, fractional excretion of phosphate, now fractional excretion of magnesium. Notice that in this formula that I've provided to you, there is this correction factor that's provided in this fractional excretion of magnesium equation. This refers to the fact that magnesium circulates bound to various species, including albumin. It is a divalent cation, just like calcium. And so in this iteration of the Phi mag equation, you'll see this correction factor which is essentially correcting for the ionized magnesium concentration, that is the free magnesium concentration in the blood. Okay, so technically you can also have a similar correction factor when you're calculating fractional excretion of calcium. Okay, some people represent Phe calciums with, or calculate Phe calciums with a correction factor for the amount that is free. Whether or not you do that will affect your your definition of normal, okay, but is reasonably equally valid, right? Whether or not you choose to include this correction factor is valid. Both ways are valid. You just need to frame shift what you consider normal if you choose to not include this correction factor. Okay, so moving on, let's then dive into the magnesium deficiencies that are related to non-renal wasting of magnesium. And once again, the urinary magnesium excretion rates expressed as 24-hour urine mag or fractional excretion of mag would be expected to be low in these syndromes. The one that you should certainly know, because it's not rare, is proton pump inhibitor induced magnesium deficiency. Now, there are similar transporters to the transport proteins in the kidney that reside in the enterocyte and mediate magnesium reclamation in the gut. And this should be of no surprise. I think we've talked in other conversation about the fact that you have ENaC channels in your gut, you have K channels in your gut, you have chloride bicarbonate exchangers in your gut. There's a lot of repurposing of some of these typical transport processes that are present in the gut as well as the kidney. And here is another example of that. And so when there is a less acidic intestinal lumen, the transport proteins that mediate magnesium reabsorption at the enterocyte are less efficient. They're less efficient at transporting magnesium. And so you would that would result in a deficiency of total body magnesium that is derived from impaired absorption of magnesium from the gut. Okay? Any questions about that? Once again, that's common. We'll see magnesium deficiency classically in our transplant patients, and most of the time we're attributing it to calcineurin inhibitors. Don't forget, however, that the PPI that the patients are receiving for GI prophylaxis on corticosteroids can also be a player. So if you um, keep managing a CNI-induced hypomagnesemia, right, with magnesium supplementation, you can't seem to get the magnesium up. You should be thinking about peeling off the proton pump inhibitor, switching it to an H2 blocker if you think it's necessary, as a way to combat that magnesium deficiency in the post-transplant patient. Not simply keep cranking up on the dose of magnesium, and then they get diarrhea, and then you get more complications from that intervention. Okay. Nutritional magnesium deficiency really is hard to manifest unless you have severe degrees of nutritional deprivation, because there's magnesium that's present in multiple foods. Keep in mind that nuts are typically rich in magnesium, and a classic complication of magnesium supplementation when given by pill is diarrhea. So this is a osmotic cathartic, right? If the magnesium citrate that you use to treat diarrhea does it by being a poorly resorbable solute. And so if you run into barriers with cranking up on the magnesium supplement, think about what are some of these magnesium-rich foods that you might try to supplement in order to reduce the pill burden and the diarrhea that the patient is experiencing. Malabsorption from any cause obviously can be associated with impaired gut absorption of various solutes, including magnesium. Fat malabsorption may be particularly problematic because fatty acids are negatively charged. We've thought about this when we talked about enteric hyperoxaluria, where fatty acids, which again are negatively charged, are binding calcium, and then that makes oxalate more available for reabsorption by the gut. Here we are in the lumen. So similarly, fatty acids, a negatively charged species, can bind some of these other cations, including magnesium, resulting in impaired absorption of magnesium. Okay, but again, diarrhea, chronic diarrhea of any cause is a classic or common cause of magnesium deficiency. Theoretically, you can also have dermal losses of magnesium when you have a burn patient or you have a Stevens-Johnson's syndrome patient, but that's not a typical cause of magnesium deficiency. Moving on to redistribution as a potential cause. I've already stated this briefly in the algorithm above. Hungry bone syndrome, pancreatitis. Once again, think about hungry bones being a form of redistribution, hypocalcemia or pancreatitis. That's in your differential for hypocalcemia as well. And so calcium and magnesium share similarities. They're both divalent cations, and so they can both manifest or they can both occur in these clinical syndromes. Hungry bone syndrome can result in magnesium reclamation by the skeleton when severe hyperparathyroidism is rapidly resolved post-surgically. Okay, let's then move on to some of these more complex concepts, and those are your magnesium deficiencies from renal loss. And remember, think about dividing this into thick ascending limb and DCT transport defects based on whether or not calcium excretion rates are high or low. Okay, so in typically all of your thick ascending limb defects, similar to your Bartter syndrome, you would expect to see high urinary calcium excretion rates. And so let's start going through some of these defects. Loop diuretic therapy and Bartter syndromes are certainly causes of magnesium deficiency. But interestingly, even though more of your filtered calcium, magnesium is reabsorbed in the thick ascending limb than in the distal convoluted tubule. In fact, magnesium is unique in being a solute that is mostly reclaimed in the thick ascending limb. So in most other instances, most of your filtered load of a solute is reabsorbed in the proximal nephron. Okay, but magnesium is different. It's even different from calcium. Most of your filtered calcium is reabsorbed in the proximal tubule. But that's different. That is not the case with magnesium. Most of it is being reabsorbed in the thick ascending limb. And so one would predict that if I had a Bartter syndrome, I would have more consistent hypomagnesemia than if I had a Gittleman syndrome. But that's not true. Gittleman's more consistently manifests magnesium deficiency, which is an interesting finding. And that would presumably translate into differences with loop and thiazide diuretic dosing as well, that the defects in or the deficiency in magnesium should be more problematic when you're giving thiazides versus thick ascending limb transport inhibitors like furosemide. Why is that? Well, it's not quite clear, but the simplistic understanding would be if I inhibit transport in the thick ascending limb, then I have a DCT which can upregulate magnesium transport in that scenario. So that's sort of the intuitive explanation of why, again, DCT transport defects are more consistently manifesting magnesium deficiency as opposed to thick ascending limb defects. Again, there's this opportunity for reclamation of magnesium in the DCT. If, however, I have a deficiency in DCT transport, I don't have a subsequent tubular segment to upregulate magnesium transport and therefore mitigate that wasting of magnesium. Okay, so that's an interesting aside. Let's then again go through these individually. Remember, your Bartter syndromes are number 6 in variance. They can be defects in the transport or recycling of potassium into the lumen. That is one possibility. Let's review again the overall transport process of magnesium in this segment of the nephron. So here we are in the thick ascending limb. Notice that similar to calcium, we have magnesium transport that is happening through a paracellular pathway. This depends on the creation of a lumen positive. Let me get my pencil. It depends on a lumen positive potential difference to push this paracellular transport of magnesium and calcium through these tight junctions, which, by the way, are gated by claudins. We're going to talk about claudins next as a cause of magnesium wasting. But again, I need to create this lumen positive potential difference, right? This is in contrast to the lumen negative potential difference we're always talking about in the collecting duct that is driven by reabsorption of sodium via ENaC. Here we're talking about the creation of a positive potential difference in the lumen, and that is occurring through these transport events. Remember, I have the reclamation of sodium, potassium, and 2-chloride through NKCC2, right? And that is electroneutral transport, 2 chlorides, 2 cations, potassium and sodium. But when that potassium recycles through ROMK back to the tubular lumen, then I will create a lumen positive potential difference. It's the recycling of this K that creates that lumen positive potential difference. Okay? But if I have defects in any one of these transporters, NKCC2, ROMK, the Barton transport or the Barton subunit of this transport channel, which includes Barton and these chloride channel subunits, CLCKA and CLCKB. These are all mutations that can result in Barters. These are all, including this gamma subunit of sodium potassium ATPase. These would all ultimately back influence the creation of a lumen positive potential difference and therefore impair magnesium reclamation through the paracellular pathway. Okay, so this would also explain why these thick ascending limb defects are characterized by high urinary calcium excretion, because it's the same lumen positive potential difference which drives paracellular calcium absorption. So if I'm impairing any of these processes that are generating this lumen positive potential difference, I would have both magnesium and calcium wasting as predictable consequences. All right, so let's get back to the text. Here we go. All right. Now, one form of Barter's is an activating mutation of the calcium sensing receptor. Hopefully you recall that when we talked about autosomal dominant hypocalcemia. That is an activating mutation of the calcium sensing receptor. It can manifest as hypocalcemia because of the activation of CASR suppressing PTH. But don't forget, that is another form of Bartter syndrome. So you can have K wasting, magnesium wasting, all of that. Now, if I have severe hypercalcemia through that same Barter's pathway, right? That calcium sensing receptor can be activated, not through a mutation, but in this case from calcium itself, and that can result in salt wasting, K wasting, and magnesium wasting. Okay? Moving on to these disorders of the claudins. So these claudin proteins are throughout the nephron. In general, they mediate paracellular transports of various solutes. There's multiple claudins. The ones that are important in this segment of the nephron are 16 and 19. There's also a claudin 14, which is a regulator of 16 and 19, or associates with 16 and 19. But mutations in any of these claudins can result in this phenotype of hypomagnesemia with hypercalciuria and nephrocalcinosis. Okay, so this sustained hypercalciuria over the life of the individual results in this predisposition to nephrocalcinosis. So the name is very descriptive and helps with even phenotyping and understanding the physiology that underpins this form of magnesium wasting. Again, this is a genetic disease. It's not acquired. So it happens, at the life of the individual, and it starts at the start of life. And so this can present certainly in childhood, okay? These individuals can develop progressive renal insufficiency as a result of the nephrocalcinosis. And then nephrocalcinosis itself can start to cause additional transport defects. So often when you have nephrocalcinosis, that's a scenario in which you have uh, a um, a confusion or a classic story of chicken versus egg, right? So RTA can beget calcium phosphate nephrocalcinosis, right? That chronically alkaline urine can beget nephrocalcinosis, but nephrocalcinosis can also beget distal tubular transport defects, including RTA. So this nephrocalcinosis and RTA association is not always, we don't always know which came first. Okay, here's another example in which nephrocalcinosis from a particular defect may later manifest as RTA. Okay. Again, the pathophysiology is revolved around those paracellular proteins, the claudins that mediate paracellular transport of calcium and magnesium. And there is also claudin expression in the eye that is present. And so you can have, if I remember correctly, a coloboma as a manifestation of the eye abnormalities with this claudin 19 mutation. Okay, so that is another way, an aspect of the syndrome to be aware of. That would not be present for the claudin 16 mutation, but it would with the claudin 19 mutation. Okay. We talked about autosomal dominant hypocalcemia, which is another, again, let's say, flavor of Bartter syndrome. Barter's would typically be manifest when you have Barter's is typically a recessive disease. And so if you've knocked out both calcium sensing receptor um, genes, then that is how you can manifest overt Bartter syndrome. Those patients would also I'm sorry, I said knockout. I meant activating mutation. Sorry, I misspoke. So these are activating mutations of the calcium sensing receptor. So these patients would have severe hypocalcemia in that scenario. And then again, K wasting, magnesium wasting, calcium wasting. Now, if you have only one mutation of one of the genes, right? Not not both genes that are mutated, but one activating mutation, you can have more subtle magnesium wasting, K wasting, and salt wasting. Okay. Let's then move to distal convoluted tubule defects. Let me just take a view of some of the ground that I'm going to cover here. Oh, I should be able to finish this today. Excellent. All right, so let's talk about distal convoluted tubule defects. Once again, similar to Gittleman's, you would typically see hypocalciuria. Let's make that make sense as opposed to rote memorization. Okay, And so let's bring it back to the tubular transport map. Go to our DCT. Here we are in the collecting duct. Here we are in the DCT. Okay, so notice that I have a variety of magnesium transport defects, a variety of root causes that can ultimately cause magnesium wasting. Okay. The most intuitive is I have a defect in TRPM6. Remember, you have in the intestine TRPM6 and TRPM7. You probably have TRPM7 expression here in the kidney as well, even though I've not represented it. But what's most well described is magnesium transport via TRPM6 transporters in the apical membrane of the distal convoluted tubule epithelial cell. So if I have a mutation in TRPM6, it stands to reason that I may have magnesium deficiency or magnesium wasting. Okay? Now, we'll talk about the EGF receptor as a classic and common form of acquired magnesium deficiency. So you'll recall that in cancer therapy, patients are often receiving EGF receptor antagonists. One of the first generation EGF receptor antagonists is cetuximab. It's classically used in colon cancer pretty commonly. And so that predictably causes magnesium deficiency because the EGF receptor regulates TRPM6 expression. Okay, it upregulates TRPM6 expression. So if I block EGF receptor with cetuximab, okay, then I would downregulate TRPM6 expression and develop magnesium wasting. Okay. Now, there are tyrosine kinase inhibitors that are commonly used in cancer therapy. So these are typically small molecule oral pills, not injectables, right? Tyrosine kinase inhibitors commonly used in cancer therapy. Some of the signaling events that are downstream of EGF receptors involve tyrosine kinases. Tyrosine kinases differ in their specificity for these growth factor receptors. Some tyrosine kinases have greater specificity for VEGF receptors. Some have more specificity for EGF receptors. As a class, they generally block multiple growth factor receptors, but again, there is specificity, some specificity across this class. So there's some drugs that are more commonly associated with magnesium deficiency than others, based on, in general, how much specificity they have for the EGF receptor and their downstream signaling events. Okay, so notice that magnesium forms or serves as a gating function with this calcium transporter. So TRPV5, we've talked about before, this transporter is gated by magnesium. And so let's walk this out. If I have a defect in absorption of magnesium via TRPM6, it stands to reason my intracellular magnesium concentration will be reduced. If intracellular magnesium concentrations are reduced, I will have a release of the inhibitory effect of magnesium on TRPV5, and therefore I will be more avidly reabsorbing calcium. Once again, in general, if I have a defect in the DCT, intracellular magnesium concentrations may be diminished, and so I would then expect to see a defect in calcium. I will expect to see upregulations of calcium reabsorption via TRPV5. Okay. Now that rationale doesn't fully translate because there are defects in basolateral transport of magnesium that have been described as DCT defects in magnesium reclamation. And so you would predict that intracellular magnesium concentrations in that scenario are not terribly low. So I will say that I've said this, I'll say this from two different dimensions, that hypocalciuria is not a perfect test for targeting DCT versus thick ascending limb as the source of the magnesium deficiency or the site of the magnesium deficiency, right? And that one reason I've sort of said, well, what happens if I have a defect in basolateral transport of magnesium? Okay, that would predictably result in intracellular magnesium concentrations that are elevated, and so I wouldn't potentially be hypocalciuric. That's point number one. But there are other things that affect urinary calcium excretion. This cartoon story of calcium being a perfect biomarker for Gittleman's versus Barter's is a bit false, okay, in real life. What are some other things that can lower my calcium excretion? Well, if I get volume depleted, I might be upregulating proximal tubular transport of calcium. And even if I have a thick ascending limb defect, I might not be terribly hypocalciuric if I'm very volume depleted. Okay, if I measure urinary calcium after a large calcium load, either parenterally or even by mouth, my urinary calcium excretion can, particularly if I'm using a spot specimen of phe calcium, may not be low, even though I may have a DCT defect. Okay, and so urinary calcium excretion rates are not perfect barometers for um, targeting DCT versus thick ascending limb. I'll make one last point. Let's suppose I have a patient and I give them, they're in the hospital and they present with hypokalemia, and then someone does a 24-hour urine to evaluate the urinary K and calcium in that patient, but the patient got normal saline. So normal saline would predictably increase your urinary calcium excretion rate. And so it's quite possible that, yes, you have Gittleman syndrome, which typically is associated with hypocalciuria, but you volume expanded the patient, and that would increase the urinary calcium excretion rate. And so that is not, in that case, a reliable test for DCT versus thick ascending limb defects. Okay, so soften what you may have learned in textbooks about Gittleman's and Barter's, as well as even these targeting the deficiency of targeting where the defect in magnesium transport is occurring, thick ascending limb versus DCT. Questions about that concept?
So does that mean you just do the genetic testing for both Barter's and Gittleman's to differentiate ultimately?
Yeah, I think the prevalence of genetic testing is now quite large or quite frequent, and so by and large, we're making these diagnoses with genetic testing in hand now. Okay. Before that, believe it or not, we were doing things like even provocative testing. So, I remember trying to figure out a case of renal K wasting by giving a thiazide diuretic to a patient and seeing if urine sodium and K excretion rates increase in response to that. So, if you had a Gittleman's patient with a defect in NCC transport, you would expect there was no effect of giving a thiazide to that individual in terms of natriuretic response and caluresis. So that's how we did it, not too long ago. But now with again, the access to genetic testing, which is not 100%, right? Uh, that is becoming another important tool in making these diagnoses. Okay, Gittleman's and thiazides, I've sort of spoken at length about this. Um, all of the physiology is not perfectly well spelt out. Why does NCC dysfunction result in magnesium wasting? There is an interaction between NCC transport and TRPM6, and even in animal models of knockout models in which NCC transport is genetically modified or inhibited, you can see this expression of TRPV5 in the apical membrane of the distal convoluted tubule downregulated. Why does that happen is not perfectly understood, but it is well described even in animal models. Okay, and I'll say one last time that hypomagnesemia is more consistent a finding in Gittleman's than in the Bartter syndrome. We talked about the EGF receptor antagonist. Again, cetuximab is one of the more common or the early first generation inhibitors of EGF receptor signaling. And then we've talked about, or I've shown you the pathophysiology in the tubular transport map. There is a syndrome called isolated recessive hypomagnesemia, which is the genetic analog of cetuximab-induced hypomagnesemia. In this case, there is a mutation in the EGF um, signaling, resulting in downregulation of TRPM6. There's another syndrome called familial hypomagnesemia with secondary hypocalcemia. By the way, we're not going to elucidate all of the various defects in DCT transport. There are actually quite a few. But let's talk about this familial hypomagnesemia with secondary hypocalcemia. This is a mutation in TRPM6 apical membrane transporters. This can result in sort of a dual pathophysiology to the magnesium deficiency. Not only would they predictably have impaired magnesium reclamation by the kidney, they would have predictably impaired magnesium absorption in the gut as well, because again, TRPM6 mediates transport processes in the enterocyte as the kidney. Okay, you can develop hypocalcemia because of the impairment in PTH signaling. Remember, that can be a deficiency of PTH secretion or peripheral resistance to PTH. We've talked about how magnesium can affect PTH at least 2 points in its physiology, right? Generally speaking, when magnesium deficiencies are profound, PTH levels are low, okay? That you have a secretory defect as opposed to a defect in responsiveness. Okay, so the name hypomagnesemia with secondary hypocalcemia provides a description of the phenotype. Again, there are a lot of other explanations for magnesium wasting or causes of magnesium wasting that are grounded in DCT transport. We have hepatocyte nuclear factor 1b mutations, which are associated also with cystic kidney disease, as well as insulin resistance. Used to be, we would call the familial form of diabetes as one of your maturity onset diabetes of the young, right? One of your Modi's syndromes. In general, the rubric seems to be migrating away from that. But this hepatocyte nuclear factor 1b mutation has a characteristic feature of cystic kidney disease as well as insulin resistance that uh, um, manifest in addition to the magnesium deficiency. Autosomal dominant hypomagnesemia, E syndrome, these are all other forms of magnesium deficiency grounded in the um, distal convoluted tubule and summarized in your tubular transport map. I'll just go over a few of these just to, uh, you know, um, spur the conversation, right? Some of these are mutations in these inward rectifying potassium channels, right? You can see that HNF1B um, regulates basolateral sodium potassium ATPase function, to name a few of these. You can also have a mutation in some of the apical membrane potassium channels that are associated with magnesium deficiency as well. Yeast syndrome is another name for some of these deficiencies in potassium channels, also are associated with a variety of CNS diseases or CNS phenotype. So the East and Sesame syndrome, this is that basolateral K transport channel. Again, it has a variety of manifestations, including um, um, hearing loss, magnesium wasting. We have again this apical membrane transport protein mediating egress, and that would cause this autosomal dominant hypomagnesemia. We talked about the HNF1B mutation causing, again, a form of diabetes, cystic kidney disease, magnesium wasting, and some other manifestations. Okay, so a lot here. I've also, yeah, a lot here, a lot of complexity to the transport of magnesium in the distal convoluted tubule. And there's entire review papers listing many of these syndromes of magnesium wasting in the kidney and particularly in the DCT. Okay, questions before I move on? We need to get to certainly calcineurin inhibitor induced magnesium deficiencies. I should have stayed on the renal transport map before I left, but let's, I'm already past it. Let's stay on this path. Okay, magnesium deficiency to a miscellaneous mechanisms. That includes many drugs that you'll see in clinical use. Okay, so your platinum analogs, classic, common cause of not only RTAs, we've talked about this in the context of RTAs, but magnesium wasting as well. So very characteristic to have magnesium wasting with the platinum analogs, oxaliplatin, cisplatin, and so our cancer doctors and our these are also used commonly in the gynecologic cancers, especially ovarian cancer. You'll see platinum analogs being used in that context. You'll see, people don't consult us for magnesium deficiency in these patients. Most of these infusion clinics have protocols for giving magnesium intravenously because it's so common, especially with some of these drugs. Amphotericin, again, another cause of RTA. We talked about back leak RTA. Hopefully you recall what that is, but also very common to have magnesium wasting with amphotericin. Aminoglycosides, pentamidine, phoscarnet, another common cause. Well, we don't use phoscarnet a lot, but I guess I would say it is common side effect of phoscarnet use to have magnesium wasting as well as RTA. Okay, so you can see that these are generalized um, toxins to the distal nephron transport. Okay, and so you would again often see RTA as well as magnesium wasting. Um, we've already gone over the fact that magnesium wasting or magnesium deficiency tends to cause potassium wasting. So I shouldn't have to reiterate that. Hopefully you recall how that happens. And I'll just give you that memory prompt. Remember, magnesium, similar to how it gated TRPV5, right? It blocks the pore of TRPV5, that mediator of apical transport of calcium. It also blocks transport through ROMK in the distal nephron. So that's that unimpaired K secretion through ROMK is the root cause of the K wasting, or theorized to be the root cause of the K wasting that is manifest with magnesium deficiency. There's also, people have done a lot of work with cisplatin. It's used in many animal models of AKI, as well as transport defects in order to elucidate how cisplatin affects the kidney in multiple dimensions. People have shown that there's reduced TRPM6 and EGF expression with cisplatin use. Okay. Aminoglycosides may have a unique form or a unique way in which they're causing magnesium wasting over and above their tubular dysfunction, their propensity to cause just generalized tubular dysfunction. Aminoglycosides are often uh, have divalent charges, and so theoretically, when given at high doses, these can activate the calcium sensing receptor and cause a Barter's-like syndrome. Okay, so that would be K wasting, salt wasting, um, calcium wasting, and magnesium wasting. Ethanol, we talked about as being a classic cause of phosphate wasting a couple of weeks ago. And this also tends to cause a magnesium wasting. So we typically see multiple electrolyte abnormalities in these patients. Abstaining from alcohol 2 to 4 weeks would generally resolve that defect. Calcineurin inhibitors. So calcineurin inhibitors have been shown to affect TRPM6 and EGF signaling, but I would say that the more clear pathogenesis of calcineurin inhibitor induced magnesium wasting is occurring in the thick ascending limb through its interaction with claudin 14, which regulates the paracellular transport of magnesium and calcium via claudin 16 and 19. Okay? Actually, I didn't go over one detail over regarding paracellular transport of magnesium, so I'll do that now. Um, so uh, you might oversimplify, and it's reasonable to oversimplify how claudin 16 and 19 mutations result in impaired magnesium reclamation through the paracellular pathway. But if you want to be nitpicky, it is not simply because these, defects in claudin 16 and 19 block the pore, right? It makes for a dysfunctional pore through the paracellular pathway. What is actually at play, at least in one paper that describes this, claudin 16 and 19 are create selectivity for sodium and chloride transport through the paracellular pathway. And so what ends up happening is that 16 and 19 allow for sodium and chloride transport across the paracellular path, but there is more permeability for sodium back leak through claudin 16 and 19, creating or augmenting the lumen positive potential difference. Okay, so there's reabsorption of sodium and chloride through the paracellular pathway, and then the ability, sodium can back leak, chloride has limited back leak, and that selectivity for sodium and chloride transport is provided by claudin 16 and 19. So again, the back leak of sodium in excess of chloride back leak creates that lumen positive potential difference, pushing mag and calcium paracellularly. Again, claudin 16 is a regulator of claudin 14 is a regulator of claudin 16 and 19, and you can see that actually I don't have it in this representation of the field guide, but it should be in an update. But there is an effect of calcineurin on claudin 14. I must have updated it into the more current version of this figure. So there is calcineurin inhibitor regulation of claudin 14, and therefore calcineurin inhibitors predictably cause magnesium wasting. We talked about through a thick ascending limb transport defect, but also by inhibiting EGF and TRPM6 function as well. So multifocal defects resulting in that magnesium wasting. Remember again, don't always anchor around calcineurin inhibitors. Think about the PPI in the patients post-transplant who have sustained hypomagnesemia. There's a mild magnesium wasting that happens with mTOR inhibitors, and then anything that expands volume would reduce the transport of magnesium in the proximal tubule, even though the proximal tubule is not where the bulk of magnesium transport is occurring. About 20% of your filtered load of magnesium does happen in the proximal tubule. And so anything that would, any volume expansion intervention would tend to cause a magnesium wasting. Any questions around magnesium homeostasis?